session on the upper limb, and we're primarily focusing on the forearm, and this time we're talking myology. So myology is just another way to say muscles. So today we're talking about muscles, and we're focusing on a particular compartments of the muscles. Can you guys hear me okay?
Yes.
Good? Okay. And before I do though, I was reflecting a little bit on the MSK strategies session that we did last week, and one of the things that I really appreciated that many of you said when you were talking about coping mechanisms with MSK is prayer and dua, or supplication, right? Because again, that just goes to show me you guys know your priorities, mashallah, and also you guys know your anatomy too, right? When you're doing dua, when you're praying, there's so much wrist movement that's taking place. Trying to make you like, you know, those schemes up there, good. There's a lot of anatomy. There's a lot, you know, when we're supplicating. Now I know some of us probably have our hands more extended, some of us probably flex them more, but regardless, we're all raising our hands and we're, you know, praying for that thing that we so desperately want, and basically we're using our body to do it. And so with that being said, we're going to be talking about the structures that make or facilitate this action that allows us to do something that is so sacred to our daily life. So with that being said, we're focusing on the muscles of the anterior forearm. By the end of today's session, you should be able to identify these muscles. So many of these muscles flex, so we're going to call them flexor muscles of the forearm, as well as their primary actions. You should be able to describe their topography / organization in the anterior forearm. You should be able to outline their course and distribution of the nerves and blood vessels. And finally, you should be able to describe the fascia of the forearm, which holds everything in place. And so the last piece of anatomy that we talked about was the radius and the ulna. So here's our lovely radius and ulna, and you can see they're held together by that interosseous membrane. And so if you wanted to visualize the radius and the ulna deep to the muscles, it would look something like this, okay? So here we have an anterior view of our forearm, and we want to imagine that we did this slice so that we can see how the radius, and I know this is the radius because it's aligned with my thumb, and the ulna, how these two are positioned within the forearm. And so if I took this slice and I looked at it from a cross-sectional 2D view, this is essentially the arrangement. So here we can see that ulna and that radius, and we can see all the musculature surrounding these two bones. So essentially, everything that's highlighted in this pink outline, these are all the anterior muscles of the forearm. So all of these muscles are grouped based on their function as well as their innervation. And so all of these muscles highlighted in pink, they're going to be primarily innervated by the median nerve as well as the ulnar nerve. And then the muscles that are situated posterior to the radius and ulna, which are outlined in green, these are going to be primarily extensors, okay? And they're innervated mainly by the radial nerve. And once again, I want to point out that these are separated by that radius, the ulna, as well as the interosseous membrane. So, as we've said before, we take on a functional approach when we teach anatomy here, meaning we try to give you guys a bigger appreciation for the functionality, what these muscles do, so that you're able to understand what happens if there is something that goes wrong. And so, the muscles of the anterior compartment, they're primarily going to do the following things. They're going to move the wrist, so primarily flexion, okay, so flexion of the wrist. They're also going to do radial and ulnar abduction, right? So radial and ulnar abduction simply means sideways movements of the hand, okay? So radial abduction is also synonymous with radial deviation. And ulnar abduction is also synonymous with ulnar deviation. Now some of you might be wondering, wait. We learned about hand abduction and adduction. That is also one way to refer to it. So if I'm just saying abduction of the hand, that means radial deviation. If I'm just saying adduction of the hand, that means ulnar deviation, right? Everybody follow? Yeah. Okay, good. So those are the movements that we see at the wrist. Now some of these muscles also pass the wrist to the digits, to the fingers. And so they're going to end up moving the fingers, and the muscles of the anterior compartment, which is all I'm focusing on today, they're going to flex the fingers. So if you guys all do a claw, okay, that's flexion of your digits. And then lastly, we have pronation, right? So we talked a lot about the joints and the bones. Today we're going to focus on the muscles that basically allow this movement to take place. And so all of these tendons, they're going to be primarily starting, or the majority are starting from the proximal end of the forearm, and they make their way towards the hand, towards the fingers, and that's what allows them to facilitate these movements. Everybody following me so far? Okay. So, before we talk about the categorization of muscles, we do need to just really quickly map out the hand. We'll just do a very quick overview. And the good thing about this lecture is, even though it's quite a heavier lecture than our previous lecture so far, a lot of what we're talking about today, we're going to revisit this week and the next, okay? So if things are not clicking 100%, it's okay. Give yourself time, we will revisit. So really quickly, an overview. When we're looking at the hand, all right, we refer to the thumb as digit 1, index finger as digit 2, and then all the way to the pinky, which is digit 5. Okay, that's really important to remember. So 1 starts with the thumb, 5 ends with the pinky, okay? As you recall from foundations, we have what we call the phalanges, which are the bones that make up the digits, all right? And so we can distinguish them by their proximity. So we have the proximal phalanx, which is the closest to the palm. We have the middle phalanx, and then we have the distal phalanx, okay? So digits 2 to 5, they all have proximal, middle, distal, except for the thumb, digit 1, only has a proximal and distal. So far, so good? Okay, my hand, the palm of my hand, the bones that are situated here, these are my metacarpals, okay? These are the metacarpals right over here, all right? And finally, the base of that, which is articulating with my radius, this is the carpals, all right? And so when it comes to the joints then, the wrist joint is the joint that we find between the radius and these carpal bones. And as you guys may recall from foundations, it makes up a condylar joint. Okay, so I know that you guys can see the actions of the wrist joint on the slide, but can you show me with your hands what is the wrist capable of doing? Okay, so I see this and this, so flexion, extension. Okay, so adduction, abduction, good. What about this? Circumduction, right. So circumduction is when you add them all together. When you add those angular movements together, that's circumduction. Beautiful. The metacarpal phalangeal joints, otherwise known as MCPs, these are the joints that we find between the metacarpals and the proximal phalanges. They are also condylar. So can you guys show me with your fingers what those actions are going to look like? Good. So that royal bye-bye, right? So flexion, extension, abduction, adduction, and circumduction, okay? Circumduction. Excellent. And then the last joints that we're going to talk about here are the interphalangeal joints, okay? And so they're distinguished by a proximal one and a distal one, with the exception of the thumb, because we only have the one joint since we have 2 phalanges. And so the joints that we find between the phalanges, these are what we call hinge joints. What are they capable of doing? Only flexion and extension. So only flexion, extension, okay? Good so far?
Yes.
Okay, we're just going to hang on to those foundational pieces so that we can carry through the lecture. We're going to dive into the details later this week when we cover osteology and arthrology. So, now that we went over the overview of the hand, let's go over the muscles of the forearm and how they act on the hand. And so the muscles of the forearm, the anterior compartment, they can be arranged in 3 layers. We have a superficial layer, which is made up of 4 muscles. They're all highlighted in blue over here. We have an intermediate layer, which is made up of 1 big muscle. And then we have the deep layer, which is made up of 3 muscles, all right? And so, as a tip, remember, these muscles, if you look at the name, it tells you something about what they are. So they are generally named based on their actions. So you're gonna see a lot of muscles today that have the word flexor, pronator, so that's telling you what it does. Sometimes they're named based on where they attach. So you're going to see carpi, ulnaris, okay? They're telling you this is where we are. And sometimes they're also named according to their shape and size. You'll see some muscles are named longus because they're very long. And generally speaking, if there's a muscle that's called longus, you know that somewhere out there there's also a brevis, okay? So just something to keep in mind. Might not be in the forearm, but it might be in the hand. Okay, So now let's get started. So let's do the superficial layer first. Here's our superficial layer. What was this region circled here? Here's our famous medial condyle, which is going to be talked about again today. And so you can see coming off the medial condyle, there's 4 muscles. The first one here is pronator teres. Okay, so pronator teres comes from that medial condyle and it attaches itself to the radius. And so you can visualize that when it contracts, knowing that the radial head is going to rotate, right? It's going to help with pronation. Beautiful. Next we see flexor carpi radialis. So again, look at the name. It's a flexor, okay? It's going towards the carpals and it's traveling along the radius, okay? Flexor carpi radialis, okay? What is it going to do? Flexion, and because it's along the radial side, what is it also capable of doing? Radial deviation. Everybody follow? So because this muscle is coming off and it's traveling along the radius of the carpal bones, it can also deviate the hand towards the radius. Okay? Next, in the middle we have palmaris longus. So palmaris longus is in the middle, and it's a relatively small muscle, a very small thin muscle. And as it's going towards the hand, it actually becomes this wide triangle. Okay? This is known as our palmar aponeurosis. Okay? Palmar aponeurosis. So it's this wide triangle, which is believed to help with strengthening our grip. Okay? Now, palmaris longus, it's a very, very weak flexor. Okay? So it's not a very main contributor to flexor, and its other action, like we said, is going to primarily to tense the palmar aponeurosis when we're trying to hold on to something. Okay? And then lastly, we have the flexor carpi ulnaris. So again, just going off of that naming strategy, so it's a flexor, it's going towards the carpal bone, but it's traveling alongside the ulnaris, meaning it's capable of flexion and ulnar deviation. Beautiful. So all these muscles, as you can see, they're coming off that medial condyle, and because there's so many flexors that come off of it, sometimes we just call the medial condyle that common flexor origin, CFO. Okay? And in terms of innervation, which we will repeat multiple times, all 3 of these muscles are innervated by the median nerve except for the flexor carpi ulnaris. And so the ulnaris pretty much gives it away. Okay? So that's how you can remember it. Okay, so here's a little bit of a FYI. So palmaris longus, not all of us have it. In fact, 15% of the population don't have a palmaris longus. So palmaris longus is what we call an accessory muscle. Some of us have it, some of us don't. And sometimes, even in the same individual, you might have it in one hand and you might not have it in the other. And so there's an easy way to tell if you have palmaris longus, and we can do that right now. So if you basically take your hands, and if you pinch your fingers like this, and you flex your wrist, and take a look at the anterior side of your wrist right over here, okay? If you see 2 lines emerging like this, you know that you have the flexor carpi radialis and the palmaris longus. So there's that palmaris longus, it's in the middle. So 2 lines tells you you have palmaris longus. If, however, you only see 1 line, that 1 line is flexor carpi radialis. Meaning you don't have palmaris longus. One way. Okay guys, I'm just going to repeat it because I don't think everyone got that. I was just talking. I know it's exciting. I know. You all have something to talk to your family about today. So, ladies. So just to recap. So if you pinch, and what I actually like to do, what I find to be even more helpful, is as I am flexing my wrist, if I put a bit of resistance, if I see 2 lines show up, those 2 lines represent my flexor carpi radialis and palmaris longus. If only 1 line shows up, that's just my flexor carpi radialis, meaning I don't have palmaris longus. Okay? And like I said, sometimes you might have it in one hand and you might not have it in the other. Okay? There you go. I got you. Okay. Again, I just given you some pretty great gossip for the rest of the week, so you guys can talk to your family and all that stuff. Okay. Here's another really helpful piece. Ladies. All right. Here's a really helpful piece, and I would love to share once I know everybody's listening. It's going to help you guys with exams. Woo. So another way you can visualize the superficial layer is if you place your hand along your medial condyle in a diagonal orientation, just like that image, and if you have that first digit going towards the radius and the other three towards the wrist, that is basically the distribution of the muscles of the superficial layer. So you have pronator teres, and then the next one that's along the radius is? Good. And the one in the middle? And then the last one along the ulna? Right. And notice the first letter of each one. P, F, P, F. Pass, fail, pass, fail. Okay? So that's how you can remember. You will all pass, inshallah. But that's how you can remember. P, F, P, F. Pass, fail, pass, fail. So that's how you can remember the orientation of these muscles. Okay? Okay. So we finished with the superficial layer. Now we're going to talk about the intermediate layer. And there's only one muscle in this layer, and it's a big one. It's the flexor digitorum superficialis. Okay? You're probably wondering, okay, wait. We're in the intermediate layer, but now this guy's called superficialis. The reason being is that this muscle is superficial in relation to a deeper muscle that has a similar function to it. Did everybody get that? Yes. So yes, it's called superficialis, but that's because it's named in reference to a similar muscle that's just deep to it, which we'll talk about in the next slide. Okay? So flexor digitorum superficialis is a really interesting muscle. It has a very large muscle belly. So again, it's just coming off below that medial condyle, right? It's traveling along the radius and the ulna, and it's going over superficially to the carpal bones. It goes to the phalanges, but it doesn't go all the way to the distal phalanges. It only travels to the middle phalanges. So let's take a closer look. Here's that hand once again. There's our MCP joint, our PIP, and our DIP. Everybody follow? Yes. Okay. And so here's a basic schematic of FDS, so flexor digitorum superficialis, all right? You can see that this muscle gives rise to 4 tendons, okay? None of them are going towards the thumb. That's really important. So they're all going towards digits 2 to 5. And as they're approaching the middle phalanges, each tendon splits, kind of like a snake's tongue, okay, for superficialis. And so each ending goes on the sides of that middle phalanx. What's really important here is basically this question that I'm about to ask you. Does FDS act on the distal interphalangeal joints?
No.
No, why?
It's unconnected.
Yeah, it's like the distal's over there and the proximal is down there, right? So it doesn't cross, FDS does not cross the distal interphalangeal joints. So it's not going to flex here. So then, follow-up question, where is it going to flex? The proximal interphalangeal joints and the MCPs, okay? So MCPs and PIPs, okay? So that's what the superficialis acts on. Again, because the tendons simply do not go to the distal phalanges, that means they don't cross the distal interphalangeal joint. FDS does nothing there. It only acts on PIPs and MCPs, okay? In terms of its innervation, it's innervated by the median nerve, okay? So I want you guys to pick up that pattern. So far, there's quite a few muscles innervated by the median nerve, okay? Good. All right, that was easy. One muscle out of the way. Now in the deep layer, the final layer, and we have 3 muscles. We have what we call the flexor digitorum profundus. Profundus in Latin means bottom or deep. So now you know why that other muscle was called superficialis, because it's named in relation to profundus, okay? So FDP. And so profundus, again, it's going to be coming off, right, that ulnar side, right below the condyles, and it's traveling all the way superficially to the carpal bones, to the digits. Again, notice nothing goes to the thumb from FDP, okay? And unlike FDS, it goes all the way to the distal phalanges. So let's take a closer look. Here was our close-up hand with flexor digitorum superficialis. We can see the tendon stopping at the middle phalanges. That's in purple. And then our flexor digitorum profundus coming off just underneath it, deep to it, traveling all the way to the fingertips. So now, here's a question. What does FDP do? What does it do at the distal phalanges?
Flexor.
Good, why?
Flexor.
Because it crosses the joint. Okay, so flexor profundus flexes the distal interphalangeal joints because it crosses. What about the other joints? Does it do anything there? Okay, why? Because it also crosses the joint. Okay, good. Everybody following?
Yeah.
So if a muscle is crossing the joint, if the muscle is crossing the joint, it's going to act on that joint. Okay, especially if that joint, the basically classification is capable of that movement. Okay, excellent. So alongside flexor profundus, we have flexor pollicis longus. So that's our first pollicis muscle so far. Anyone know what the pollicis stands for? Just show me. Don't tell me. Thumb. Okay, so pollicis means thumb, all right? So flexor pollicis longus, this muscle is a deep muscle, and you can see that its tendon goes all the way to the distal phalanx of the thumb, and that's what allows us to flex the thumb, okay? And so it's called longus because it's long. Again, side note, there is a flexor pollicis brevis, but it doesn't live in the forearm, it lives in the hand. You guys will learn about it in the hand myology lecture. Everybody following so far?
Yes.
Okay. Lastly, we have the pronator quadratus. So we talked a lot about pronation so far. We've established there's pronator teres. Pronator teres, it doesn't act alone. It works with pronator quadratus to pronate the hand. And so pronator quadratus, you can see it just deep to FDP and FPL. And here is an image where it's isolated. Again, they're still all considered to be deep. And you can see it has a bit of a square shape, and that's what the word quadratus comes from. Quadratus meaning it has 4 sides. Okay, so quadratus, all right? And so what it does is it pronates, and it's going to bind the radius and the ulna together. Okay, I hope everybody that's having side conversations knows their MSK myology so far, because I wouldn't want you guys to miss on some details, all right? Just an important piece to keep in mind. When it comes to innervation, so this is an important piece because now innervation starts getting a little interesting. So flexor pollicis longus and pronator quadratus, these guys are innervated by the median nerve, okay? However, when it comes to the flexor profundus, we have dual innervation, meaning only half of it is innervated by the median nerve, the other half is the ulnar nerve, okay? Does that make sense?
Yes.
So the medial half, okay, so the half around along the ulna, that's going to be innervated by the ulnar nerve. All right. Whereas the lateral half along the radius, that's innervated by the median nerve. So do you guys recall how many muscles so far are innervated by the ulnar nerve?
2.
Name them.
This one, the half,
Okay.
and then the other one, the F, the last
Yeah.
F.
Can anyone help?
Phosphate, the other F, yeah.
Flexor compartment. So I like to think of it as 1.5, not 2.
Yes.
Right? So 1.5. Flexor carpal ulnaris and half of flexor profundus. Okay? Excellent. Beautiful. So let's just do a really quick recap. Here's a very basic schematic. We went over the 3 layers of muscles of the anterior compartment. Here's our radius and the ulna. And I've given you guys a couple of linguistic phonetic hints to remember each group. So superficially, all right, what are those muscles called again? Beautiful. And I've underlined the first letter of each one. PF, PF, pass, fail, pass, fail. Then what's the intermediate layer? I want to hear from this side. This side is so quiet, guys. Or this side. What's the intermediate?
Superficial flexor.
You sound so lovely.
Tormus.
Should hear you more often. Okay, flexor superficialis. So many S's. Okay, so remember. And then deep. Oh man, sorry, my finger was too fast. But we have our flexor profundus, flexor pollicis longus, and pronator quadratus. A lot of P's in there. So that's one way you can remember the muscles that are in the deep. Okay? Okay. So, clinical corner, medial epicondylitis, also known as golfer's elbow or thrower's elbow. Is anyone familiar with either of those terms? Okay. Has anyone ever had golfer's elbow or Okay, so basically this is a condition where you have some pain and tenderness in the medial epicondyle region because of overuse of the flexors and pronators, right? So we often see this with activities that have a lot of repetitive use of these muscles, like weightlifting, gripping tools, racket sports, that's why it's called sometimes tennis elbow, repetitive typing or writing. And what ends up happening is there are degenerative changes, right? So there's this micro wear and tear of the tendons as these muscles continue to get overused. And so this is typically presented with pain. And so you can see here, here's an MRI. And as you guys may recall from MRIs, when you see something that looks really bright in an MRI, that's representative of inflammation, of fluid, swelling. And so this is a very severe case of medial epicondylitis because you can see that tearing and that swelling of the pronator teres muscle, okay? So it's not always going to be there, right? Depending on the severity, you'll see the swelling, or sometimes in the early stages, but later on, it's not always a guarantee, okay? So that's medial epicondylitis. So here's our quick check-in. So which of the following muscles produce wrist flexion and radial deviation? So hands up for A. Hands up for B. Hands up for C. Hands up for D. Nice. I love seeing those hands in the air. Good. Okay. Flexor carpi radialis, right? Because it's flexing, and because it's along the radial side, it's going to bring the hand towards the radius, radial deviation. Okay. So by now you guys would have covered the brachial plexus. I hope you guys are studying it. Okay.
Yeah.
So the muscles of the anterior forearm are innervated by, like we said, the median and the ulnar nerve. So median nerve comes from C5T1, ulnar nerve from C8T1. You can see on this image the nerves as they're coursing along the arm. So here's that median nerve as it's traveling anterior to that humerus, and it goes anterior to that cubital fossa to innervate a lot of the muscles of the forearm, the anterior compartment. You can see the ulnar nerve is coursing alongside the humerus. It tucks just posterior to the medial epicondyle. That's why funny bone sensation right there. Travels alongside the forearm to innervate some of these muscles here. Now, it's important to know about this innervation because, again, compression to these muscles at various sites, right, could impact these nerves, and you can start seeing motor deficits. When I say motor deficits, so downstream effects with motor function, or sometimes sensory, if these nerves have sensory, okay? One really important distinction, guys, even though we can see the radial nerve and it looks like it's appearing anterior to the elbow over here, it's really important to remember that it does not innervate the anterior compartment, okay? You guys, have you had your extensor lecture yet? No? Okay, you will be covering your extensor compartment lecture either today or tomorrow. The radial nerve will pop up there a lot, okay? But it doesn't do anything for motor in the anterior compartment. So let's just, spend some time with median here as well as the ulnar. So here's that median nerve. You can see the muscles of the forearm. They've been partially resected so that we can appreciate that median nerve as it's coursing along the muscles. It's going to innervate all those superficial muscles except, good. And then in terms of the intermediate, does it innervate the superficialis muscle?
Yeah.
Yes, it does. Okay, so superficialis is innervated by the median nerve. By the time we get to the deep layer,
Half.
right, the median nerve is going to innervate majority of these muscles: pronator quadratus, okay, flexor pollicis longus, and half of flexor digitorum profundus. Okay, so profundus. Superficialis does not have dual innervation. Median nerve, it's loyal to the median nerve. Profundus, split. Okay, indecisive. Okay? Okay. Median nerve, this is really important piece, guys, in terms of the clinical scenario here. The median nerve is going to travel towards the hand deep to what we call the flexor retinaculum. So basically, that's just a thickening of the fascia that we see on the wrist, okay? And so the median nerve travels deep to it, right? Make sense? Okay. What I like about this diagram is it's basically showing you the same thing, but it's also highlighting for you the muscles that it innervates. Okay, so this is a great review image when you guys are going over the muscles and their innervation. All right, ulnar nerve. So there's our ulnar nerve. We basically stripped down all the muscles except for the ones that are innervated by the ulnar nerve. So I know it's not labeled, but can anybody tell me what this one is? Flexor ulnaris. Can anyone tell me what this one is?
Profundus.
Flexor digitorum profundus. Excellent. And so the ulnar nerve you can see here is going to innervate the medial half, right? And remember, because profundus and superficialis are going towards the digits, okay, that innervation is coming to the fingers as well. So that's why we say that the ulnar nerve is innervating the medial half to digits 3 and 4, right? Does that make sense?
Yes.
Okay. And so the nerve, now the ulnar nerve is not going to travel through the carpal tunnel. It's actually traveling through its own little tunnel called the ulnar canal, otherwise known as Goyen's canal. So Goyen's just the name of the person that has been documented to discover it. And that's superficial to the flexor retinaculum. Now, so far we've been discussing the motor functions of these nerves. They also have sensory innervation, right? But the sensory innervation of the median ulnar nerve, we only appreciate it in the hand, okay? In the hand. So when you look at the median nerve, it's going to give rise to what we call a palmar cutaneous branch. And this is going to give rise to sensation in the central portion of the hand. The rest of the median nerve is going to give branches, cutaneous branches, that are going to be sensory for the lateral aspect of the hand, so the lateral digits and the thumb, okay? As it's illustrated here by the purple innervation. Can you guys see that?
Yes.
Good. The ulnar nerve, so this is highlighted in yellow, all right? If we just, again, follow the nerve, it's going to give rise to sensory innervation for the medial side of the hand and the medial 2 digits, right? And so the branches that are going to be responsible for that are the palmar and the dorsal cutaneous branches, okay? Again, why are these important? Because when there is some kind of compression taking place, we can expect some sensory deficits, all right, with these nerves. So this brings us to carpal tunnel syndrome. How many of us have heard of carpal tunnel? If you guys have made it this far, you must have, right? You know, many of us know somebody that has it, or maybe yourselves, you've experienced it. But it's one of those cases where you experience with prolonged pressure to the anterior wrist. And so we can see that with when you have your hand on the tabletops, on keyboards, on the mouse, that prolonged pressure is pressing on the flexor retinaculum and is pressing onto that median nerve. And that can cause downstream effects, right? So we said if we're compressing the median nerve and it's giving sensation, okay, to the lateral half of the hand, then you can expect to see some tingling sensation in that region, okay? Now, the palmar cutaneous branch, if you guys refer to that last image, notice how it's coming superficially to the carpal tunnel, okay? And so it's often spared, so it's not, so sometimes the central sensation is spared, but not always, right? Just because of where that palmar cutaneous branch is. And I just want to highlight one thing here about carpal tunnel, which many of us don't get to appreciate. This image right here is a cross-section of the hand. This box is showing us the carpal tunnel. Look how busy it is. There are 9 tendons traveling through the carpal tunnel. 9 tendons plus the median nerve, okay? So 4 from flexor digitorum superficialis, 4 from flexor digitorum profundus, 1 from flexor pollicis longus, and then you have the median nerve. Why am I saying this? Because the moment you start getting that inflammation, that swelling from overuse, things get tight real fast. And so that's why you'll see that sometimes with severe carpal tunnel, one of the ways that they help to treat it or relieve it is by snipping that flexor retinaculum just to relieve that area from pressure, okay? Okay, so we're slowly wrapping up, guys. So we're gonna briefly talk about the blood circulation. Now by now you should have covered the brachial artery, right? Okay, so it's traveling along the humerus, and when it reaches that elbow region, it's going to split, giving rise to the radial and ulnar arteries. And so you can see here, as you follow these arteries, as well as their branches, they're going to supply the flexor and the posterior compartments of the forearm. And as you follow these arteries towards the hand, they're going to give rise to these vascular networks, these arches that are going to supply the wrist and the hand. I'm not going to talk too much about the arteries today because Dr. Elena has some really great slides for you where she will focus on the arteries. So for now, I just want you to just keep that distribution in mind, right? Brachial nerve breaks into the, brachial artery gives rise to radial and ulnar artery. they're gonna give rise to branches, they're gonna supply the anterior posterior compartments, okay? Now, we're coming back to the image that we started with. So here is the anterior side of our forearm, okay? There's our radius, and there's our ulna, and there's our muscles surrounding the radius and ulna. And believe it or not, we've probably covered around 75% of this content today. All these labels, all right? You probably know 70 to 75% of them by now, okay? You will have to practice, okay? We have the radius, you have the ulna, there's that interosseous membrane, and there's all of our flexor muscles that we talked about. And I want you also to appreciate that here we have our ulnar artery, and here we have our radial artery. And we can also see the nerves. Now, sometimes we can have an injury that can cause internal bleeding, all right? And in severe cases, that can cause what we call, oops, sorry, my mind is already skipping a slide. Hold that thought. Going back to this, we've named the muscles, we've named the arteries and the nerves, but one thing that you should also appreciate is that these structures, they don't survive in isolation, okay? They're all encased by what we call the antebrachial fascia, otherwise known as the deep fascia. So you guys remember the brachial fascia? You've talked about it. So basically it's that sleeve of connective tissue that wraps around the muscles of the arm. Well, it continues, but now when you are at the forearm, we call it the antebrachial fascia or the deep fascia, okay? Or sorry, it is the deep fascia. But basically this acts like a sleeve that compartmentalizes the muscles of the forearm, and some of its extensions will also help to reinforce those compartments, okay? And so once again, there is our flexor anterior side, there's our extensor posterior side. And so now, sometimes we have internal bleeding, and the problem is with this fascia is that it's unyielding. It's not going to be very flexible, right? So if you have internal bleeding or if you have edema, you start having an increased pressure, what that can end up doing is it can create swelling, and it can result in pain, as well as altered sensation of the hand, because you can visualize, as you have that increased fluid, it's pressing onto those nerves, it's pressing onto those muscles. And in very severe cases, if it's left untreated, it can lead to ischemia, it can lead to necrosis, and it can also lead to what we call Volkmann's ischemic contracture. So that's basically a permanent flexion deformity, okay? You could look up the compartment syndrome of the forearm. You will see that there are quite some graphic images because it can look quite scary if it's not treated. You can start to see blisters and bleeding on the skin. And so one thing that they usually do to help with relieving it is they do what we call a fasciotomy. So basically when they cut the fascia to drain, and so that's what they're showing you here. They would cut the fascia so that they can drain the limb from the fluid. And this can happen in the upper limb or the lower limb, okay? Okay, so we talked about a lot today. We talked about the compartments of the forearm, and we said that the anterior compartment specializes in what? Flexion, right? So specialized in flexion, and we have some pronation as well, okay? We talked about the innervation. So the anterior compartment is primarily innervated by who? And the ulnar nerve. Okay, again, the ulnar nerve innervates what?
The flexor part by ulnars and parts of the
Fundus.
Good, and the ulnar half of the flexor palpus profundus. Sorry, wow, now I'm getting confused. Flexor profundus, good. And so knowing the positioning of the nerves and the vessels, that's also quite relevant so that you know what these muscles are supplied by, and you can also appreciate what happens when things go wrong. So here's a link to the quiz. Go ahead and scan it. After that,